The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. Welcome to the next episode of TMD Demystified. I am Tony Urbanek. Today's title, I'll get right to it. I think you'll find it very interesting for those of you who are new to this podcast, and also for maybe old timers. Some of you may already know what we'll be talking about in detail because I have covered it before. But the topic is exactly how does TMD cause ringing in my ears? Actually, that will be extended into ringing, subjective hearing loss, which is fullness in the ears, feeling like you have water in your ear, and you have subjective hearing loss, and dizziness, vertigo. The reason I chose this topic is because I'm on a roll based on the questions that patients ask me to describe and educate them on exactly how this device actually works to make ringing in the ears, subjective hearing loss, and vertigo diminish and go away. Now, I know I'm covering material that I've covered before, but we're going to do it in a little more detail. I think for those of you who don't know about it, it'll be very, very enlightening. The information I have to share is not out of the blue. You'll learn that this is actually old information that explains this problem. Ringing, fullness, dizziness, that's what I refer to. Ringing in the ears, subjective hearing loss in the ears, and vertigo. Those three symptoms are defined by the otolaryngologist, the ENT doctors, as Meniere's disease. French clinician who named those three symptoms Meniere's disease, Dr. Meniere. I don't know the exact date, but in the 1800s, I believe. And the ENT doctors have no solution for Meniere's disease. If you go to a otolaryngologist, ENT surgeon with one or more of those symptoms, he will do a very expansive and very well worked out and examination, most likely including a MRI, and will report back to you, the patient, that you have Meniere's disease. And the patient says, well, thank you. Now I know what it is. What can we do about it? And the doctor, the ENT doctor, will shake his head, roll his eyes, or just look at you and say, we do not have a solution for Meniere's disease. Now, they may do some symptomatic motions of drugs and decrease your salt and all kind of things that are not effective for the problem. But that is the current state of Meniere's disease and those three symptoms. Now, parallel to that, those doctors who see patients with TMD are well aware, well established, well agreed upon among ourselves that tinnitus, subjective hearing loss, tinnitus, ringing in the ears. By the way, it's tinnitus, not tinnitus, based on the Latin tinere, Tinnire, to ring. Tinnitus is based on the Latin to ring, and you know, doctors got to speak in Latin to sound important. So we don't among ourselves, we don't call it ringing in the ears. We call it tinnitus, but not tinnitus. Tinnitus would be some kind of form of inflammation, itis, tinnitus, itis of the tin, maybe. So tinnitus is the proper word, a subjective hearing loss. You go to the ENT, you go to the audiologist, and they check your ear, and they go that your ear is working just fine. They do their magic, and you go, no, 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 no. I'm telling you, I cannot hear out of this ear as well. Well, that subjective hearing loss feels like water in your ear. And then dizziness, vertigo. Difference between dizziness and vertigo is vertigo actually by definition is you either feel you are spinning or the room feels like it's spinning. Where dizziness is just that feeling you get in the morning where you get out of bed too quickly. Orthostatic hypotension. Okay, we're getting a little deep in the weeds here. I don't mean to do that. Let's stay on track. So what is going on here when the doctors who treat TMJ problems, TMD, are well aware that those three symptoms are associated with the problem, although they don't know why, they don't know how, and that's what we're going to cover today very quickly and very easily, and I hope this will, if nothing else, get you interested in treating this problem for your patients because, frankly, there is a tremendous number of patients who not only have Meniere's disease, but by my exploration and investigation, 45% of females have temporomandibular joint symptoms in the United States of America. Most of them think their symptoms are coming from some other problem other than their temporomandibular joint. Just as a brief statement, temporomandibular joint disease should appropriately be called inflammation of the temporomandibular joint is really what TMD is. And then how does inflammation within the joint cause ringing, fullness, dizziness? Well, that's what we're going to learn here. So we've talked about before how inflammatory change within the temporomandibular joint can create the muscles to get tight, pull on the bone. Where it pulls on the bone, stimulates the nociceptors. Nociceptors create the pain, and wherever the muscles of mastication, wherever the muscles control the head and the neck are inserted into the bone is where the patients will feel the pain. Well, ringing, fullness, dizziness, tinnitus, subjective hearing loss, and vertigo, it's a different mechanism, totally different mechanism, but caused by chronic inflammation within the temporomandibular joint. That is for sure. So this is what you need to look at here. I'm going to pull up a couple slides, I hope, and share my screen for you. Hang on a second. There we go. Let me get, all right, fine, we can keep that there. So this is a diagram, an anatomical diagram out of a 1953 issue of Gray's Anatomy, which was this actually, this 1953 text was gifted to me by the chairman of the Department of Anatomy at Indiana University because we were talking an anatomy issue and he referred me to Gray's and I said, I don't have a Gray's. And he asked me why. And I said, I couldn't afford the $100 and whatever it was. And he literally gave me his personal copy dated 1953 of Gray's Anatomy. And that's where this comes from. So I want to bring to your attention, this is looking, get you oriented. This is the temporal bone. Keep in mind, besides my degrees in dental and dentistry and medicine, I also have a degree in cell biology and anatomy from Indiana. And so familiar with certainly the anatomy of the head and neck. And this is the temporal bone, the external artery canal, the glenoid fossa of the temporomandibular joint. So this is anterior, this is posterior. Bring a few features to this diagram to your attention. The juxtaposition of the posterior aspect of the glenoid fossa of the temporomandibular joint to the anterior wall of the external artery canal. That anterior wall is, in most cases, very paper thin bone between the temporomandibular joint and the external auditory canal. But what I want to bring to your attention on this particular diagram is something called the petrotympanic fissure. The petrotympanic fissure is a fissure, basically a potential space, a potential area, a potential tract that can go from the posterior aspect of the glenoid fossa of the temporomandibular joint directly into the middle ear. We'll take a look at the diagram of the middle ear here in just a moment, but let's stay on this slide. So we have you oriented anterior, posterior, temporomandibular joint. By the way, after operating, literally being inside over 2,000 temporomandibular joints surgically, myself, half of those being open joint surgeries and half of them being through an arthroscope, I can attest that 100% of the time the temporomandibular joint had chronic inflammation in it. That was proven by 100% of the operations that I did. A piece of tissue was removed from the joint one way or another, either through the arthroscope or as an open joint procedure, and sent to the pathologist. And the first line on every pathology report that was returned over 2,000 times was chronic inflammation as the first line of the pathology report. So you can assume that you have chronic inflammation within the temporomandibular joint. Now, the posterior aspect, where I'm indicating right here, of the glenoid fossa is nothing more than the posterior tissue of the meniscus, which is a area like a sponge that expands on opening and closing and filled with blood. And when it's chronically inflamed, it can get degenerated, and it looks like a diseased little sponge. But the point is how close this is to the entrance of the petrotympanic fissure or tract that goes into the middle ear. Now, here is a diagram to orient you. Now you're inside the middle ear. You're looking out through the, not through, but at the tympanic membrane. So if this membrane wasn't here, you'd be looking out through the external artery canal, but you're standing inside the middle ear, looking out, tympanic membrane, and here is the entrance of the petrotympanic fissure, also well known as the Glaserian fissure, because it was Dr. Glasser in 1680, that's 1680, he identified this fissure or tract that goes from the posterior aspect of the glenoid fossa directly into the middle ear. So if you have inflammation within the glenoid fossa, especially the posterior aspect, you can drive inflammatory fluids, maybe even cells, but fluids for sure, through this tract that Dr. Johann Glasser identified in 1680 into the middle ear. And in the middle ear is where you have the mechanisms for hearing and the vestibular mechanism, which keeps you upright. And hopefully you all studied in your anatomy and dental school a little bit about those two mechanisms and the hair cells and how sensitive they are to the environment. So I cannot say whether it's change in pH or change in the inflammatory exudates that get into the middle ear, but we know that you can drive inflammatory exudates into the middle ear, which change the composition and the physiology of the hearing mechanism and the mechanism that keeps you upright, the vestibular mechanism, which then will create, tinnitus, subjective hearing loss, feeling of fullness in the ear, and vertigo, dizziness, and maybe all three. Now, you don't have to have all three of them to make this diagnosis, but this is the mechanism that creates those three symptoms that is well known associated with temporomandibular joint disease. And this has been in the literature. You're looking at it. It has been in the literature. It has been in Gray's Anatomy for probably, well, certainly since 1953. But I think that this diagram goes before the editions, the 1953 edition. But let's just say 75 or 100 years, this has been in Gray's Anatomy. And no one has ever looked at it and determined that there's a tract that goes between the glenoid fossa and the middle ear. And by the way, you all may remember the nerve itself, because it's certainly in dentistry, it is important for you to understand that taste on the tongue is derived from the petrotympanic nerve, which comes off the facial nerve, which traverses the temporal bone within solid bone. This facial nerve, 7, is coming through the bone and protected in the bone, but there is a small nerve that comes off of the facial called the chordotympany that then traverses the middle ear and enters the Glycerian petrotympanic fissure, exits that fissure at the lateral aspect and the posterior aspect of the glenoid fossa, and supplies taste to the tongue. And that is why some patients with inflammatory changes within the middle ear will complain of burning tongue. So you will get in your dental practice, not very frequently, but you will see patients complaining of burning tongue, and they go to their physicians. The physicians have no idea what's going on. The ENT doctors have no idea what's going on, but you are literally looking at the solution for understanding why patients have burning tongue. When the middle ear contents, pH-wise or otherwise, changes significantly, it will stimulate this nerve to create the feeling of burning tongue, because the chordotympany actually supplies the sensory mechanisms on the tongue for taste. Very, very interesting. Very, 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 very interesting. So I bring this to your attention. That is exactly how TMD causes ringing in the ears, subjective hearing loss, and vertigo. Now, a couple points about those three symptoms that I've learned after treating well over now 5,000 patients just in the past 7 years or 8 years or so, that patients will complain of one or more of these symptoms, and that fullness in the ears and dizziness will go away relatively rapidly. Within the first month or two, patients will usually start to feel a decrease in the symptoms of subjective hearing loss and vertigo when the inflammatory fluids quit being pushed up the petrotympanic fissure into the middle ear. for some unknown reason, and I claim this is one part of this. I don't know why tinnitus hangs on such a long time. Although tinnitus will decrease. We see it decrease, but most often it takes a long time. 4 months, 6 months, or even longer. I've had several patients who complain of tinnitus, and it's taken a year for the tinnitus to calm down. And I probably have more than a handful, somewhere between one handful and two handfuls of patients who presented to me with their only symptom of Meniere's disease, especially tinnitus. I have a handful that their only symptom was tinnitus. And in every one of those cases, with using a device that unloads the joint, makes the inflammation in the temporomandibular joint diminish over a period of time, when the only symptom the patient complains about is tinnitus, that tinnitus will diminish and go away. I won't share with you the stories itself. They're very interesting, though. When a patient complains, I understand that I've heard that you can make ringing in the ears go away. Well, we've done that, and this is the explanation. You're looking at it right here. So, with that being said, I would really like to encourage any viewer, any doctor, any dentist, because you have to be a dentist and have some knowledge of how to use a simple device, very simple device, that unloads the temporomandibular joint according to a protocol. You have to have a protocol. You just don't put this thing in your mouth and hope for the best. The protocol is very simple. You have to wear the device, which sits in the roof of the mouth, in the anterior, and only separates the posterior teeth. And every dentist knows that all the loads on the temporomandibular joint come from the posterior teeth. That's why you chew nuts with your back teeth, not your front teeth. You unload the joint. When you unload the joint long enough using the protocol, which is 24/7, except when you eat for 2 months, and then nighttime or sleep time the rest of your life, then the inflammation, chronic inflammation in the temporomandibular joint diminishes, and all of the symptoms, the painful symptoms and the not painful symptoms, ringing, fullness, dizziness, Meniere's disease, diminish and go away. It has to be monitored. The patients need to be monitored to make sure that they know how to use it, because it's a tool to use. You have to learn how to use this tool. But you can speak with it in your mouth. It's very unobtrusive. Unlike other things, there are a few other things that separate the back teeth. One is the NTI. You can't talk with the NTI. You can't use it according to the protocol. The quick splint is a very temporary kind of thing. They promote it as a very temporary emergency kind of treatment that separates the back teeth. It certainly doesn't last very long. This device will last indefinitely as long as the patient keeps it clean with toothbrush and toothpaste and keeps it in the case that we supply with the device, because if you don't keep it in the case, something bad's going to happen to it. You're going to leave it on a lunch tray. The main offenders are the dogs. They are the main offenders. We have so many patients, the dog got it. And I have had 3 ladies tell me their stories of how they ran over that device with their cars, which is a very interesting story. They all did it the same way, went through the fast food drive-through. Instead of putting it in the case, they put it in their lap. They ate their food. They forgot it was in their lap. They got out of the car, and either their car or somebody else's car ran over it and put it into pieces. All right, we're getting off topic here. This device will make, according to using the protocol, tinnitus, subjective hearing loss, and vertigo diminish. That is an amazing feat. And I encourage anyone who would like to do this to join our network of doctors who use this patented device. You have to be licensed to use it because it is a patent on it. And if you violate the patent, then we have a problem. But I invite anyone to become a network provider, because I can't see all these patients. I and my associate here in Middle Tennessee, and the now doctors in 18 states. We have doctors in 18 states who use the Urbanek device and protocol, but nowhere near enough, nowhere near as many doctors as necessary to treat 45% of females who have these symptoms. Most of them think they either have no idea what's causing it, or migraine headaches and they're on medication, or worse, We've talked about some of that in the past. If you'd like to discuss it with me, I'm available at tony@tmjservices.net. Our website is www.urbanektmj.com. Until next time, I will go on with the roll, and we'll pick out another topic to discuss on TMD Demystified. I am Tony Urbanek.